I am Betsy John Lane, the Family Support Specialist with the North Carolina Down Syndrome Alliance. Tori England, our program coordinator, is also on our call tonight. So we welcome you to our virtual speaker series, and we host it as the NCDSA in collaboration with Coastal Buds Down Syndrome Network of Onslow and Carteret counties, the Down Syndrome Network of Greater Greensboro, Down Syndrome Association of Greater Winston-Salem, Down Syndrome Association of Greater Charlotte, and the High Country Buddy Walk. And we want to thank you. We actually had to work through some technology patience as Teams and Apple don't always like to speak to each other. And as well as technology always makes updates. But we are just so thankful for you kind of working through those issues with us. We did want to let you know, if you do have questions that arise throughout our time tonight, feel free to pop them into the chat. If for some reason your Teams does not have that chat feature, feel free to send me a text on that cell phone number, 919-532-9207, or email us. Michele Mattox is going to share some great resources with you tonight. And as well, you will receive a follow-up email that will kind of encapsulate everything that she shares tonight, a feedback survey, a recording of the presentation, and her slides that she is graciously going to share some of those rich resources with us, as well as just some feedback from you all as families and how you can help shape and make our virtual speaker series stronger and meet the needs of what you all need for your families and individuals with Down syndrome. So again, questions are welcome through the chat feature. And again, we just want to welcome you to our virtual speaker series of 2025. Tonight, we are focusing on obsessive-compulsive behaviors, promoting independence, and when is there a cause for concern, with amazing Michele Mattox, LCSW. This insightful webinar will explore the common mental health concerns in the Down syndrome community, specifically obsessive-compulsive behaviors, and learning how to identify when these behaviors are harmful and discover effective strategies for managing them, and understanding if there is ever further evaluation, more steps, and what can best serve you and your family. So again, welcome NCDSA families, and welcome Michele Mattox. You may take it away.
All right, thank you so much for the introduction. Thanks for having me, to all the Down syndrome organizations that are involved. As Betsy John mentioned, tonight we're focusing on obsessive compulsive behaviors, and are they promoting independent living, or is there a cause for concern that we might want to get checked out? For those of you that do not know me, again, my name is Michele Mattox, and I am a licensed clinical social worker. I am local to Charlotte, North Carolina, and Fort Mill, South Carolina. I live about 2 miles over into the South Carolina line outside of Charlotte, so I still pretty much claim Charlotte. I have been involved in the disability community for a little more than 20 years now. Everything from coaching Special Olympics gymnastics to teaching in a life skills classroom, volunteering in the community here. And I do not have a family member with Down syndrome, but after all of these years of working in this community, they are my favorite people. So when I developed my business in 2020, I knew that I wanted to develop it to specifically serve the Down syndrome population. So my private practice is called No Limits Counseling and Coaching. My business is primarily virtual, and as I mentioned, I'm licensed in both states, so I serve clients throughout North Carolina and South Carolina. And I specialize in providing counseling to teens and adults with Down syndrome. So most of the focus tonight will be on teen and adult issues. However, if you have younger children, all of this information is still relevant and good to know. I also provide relationship coaching, dating, and sexuality workshops to individuals of all IDD diagnoses. So that is a little bit about me. Just a brief disclaimer before we get started. The content in this presentation is intended to educate and provide ideas for self-help and should not be used as a substitute for therapy or mental health care. And if you are not sure about where you can get that care, please reach out to me and I'll try to connect you with someone. All right, so getting started, let's talk a little bit about some common characteristics that are seen in the Down syndrome community. Of course, we all know that an individual with Down syndrome is just that. They are all unique individuals, but there are some common characteristics that people have described and often seen throughout the Down syndrome population. Some of them are self-talk, which will sometimes include imaginary participants, whether it's one of their favorite famous people or somebody they have a crush on, or it's just someone that they've made up. And this is normal and typical for even teens and adults with Down syndrome. They are most often visual learners and have a strong visual memory. They sometimes have difficulty recognizing the passage of time. So if you've ever asked your family member, well, when did that happen? It's usually kind of hard to get a clear answer about when the event actually occurred, or there might be some confusion around that. They often have heightened sensitivity to others' emotions, which a lot of parents have described to me that they feel like their family member has almost a sixth sense, that they just know when someone is feeling stressed or when someone is in a bad mood, and they know how to make them smile. Oftentimes they will experience delayed grief, and sometimes this will concern families if they've lost a loved one or a grandparent, somebody that was close to them, and the parents are like, I don't understand why they're not more upset. And sometimes it just takes them longer to process what happened and to even recognize that it's a sad thing because they might not understand the permanency of it. So delayed grief is actually a common characteristic. They might have a slower pace. Some of you may have recognized this when you're trying to get out the door in the morning. It might take them a little bit longer to get to the car or wherever you're trying to go. And then the main one we're going to focus on today is it is very common for people with Down syndrome to have a preference for repetition or sameness. So they might like to do the same activities over and over, or they like to have the same schedule that's predictable every day. And this is in fact so common that Dr. Chicoine and Dr. McGuire, when they wrote the book Mental Wellness for Adults with Down Syndrome, they actually identified a term and they call it the groove, that many individuals with Down syndrome seem to get in a groove or a pattern of behaviors. And this is not necessarily a bad thing. A lot of times, after I go through this list of common characteristics with families, it almost makes them feel better because they're like, oh, wait, I've been worried about some of these things. I didn't realize that it was so common. So I hope that that was a little bit helpful and let you let out a breath a little bit. Now, what do these characteristics indicate for mental health and Down syndrome? And on the side, you'll see a picture of the book, Mental Wellness in Adults with Down Syndrome. This is a good resource if you've never heard of it. You can order it sometimes on Amazon, but I don't think it is in print anymore. So if you would like to access it, the Adult Down Syndrome Center resource page, which I'll list all of this at the end of the presentation, they have a free copy of the book that you can either read online or print out. But it has a lot of excellent information about the things we're talking about today and all things health and wellness, pretty much. So a few things, these common characteristics may interact with mental health issues is, so self-talk, it could be misdiagnosed as psychosis if the individual with Down syndrome is seeing a clinician or doctor that maybe doesn't work with this population a lot. They may not understand that self-talk is often used as a coping skill for individuals with Down syndrome, or it helps them process their day or just slow the world around them down a little bit. So if they're like, well, they're talking to themselves or they have this imaginary friend and the clinician does not know about this, then they might think that they're hallucinating. So I will talk a little bit later how important it is to try to find clinicians, although I know it can be hard, that are familiar with Down syndrome. When we're talking about their strong visual memory, that is a good thing that they can remember all these details of events of their life, unless it was a negative event or if something traumatic happened to them. That may be more stressful to them that they're so good at bringing up all these details. And that combined with difficulties with recognizing the passage of time. So if you think about a negative event happening and they don't always recognize that it happened a long time ago, they may experience feelings and emotions like that traumatic event just happened yesterday. So you can see how this would increase stress for individuals with Down syndrome. Another thing when we talk about the sixth sense or being very intuitive to others' emotions is that we have found that sometimes individuals with Down syndrome will mimic or demonstrate stress or depressed symptoms of family members or roommates. This is commonly seen sometimes in families of my older adults, if they're living with elderly parents and maybe they've slowed down or declining mentally or physically in some way. We've seen adults with Down syndrome that seem to mimic those depressed behaviors and may not want to be involved in other things. And they're kind of just sitting around, just like the person that they're observing that is stressed or depressed. And then, as I mentioned, with delayed grief, it may be something that is reoccurring. So if they don't actually show the emotions around the time that somebody passed away or there was a big change in their life, it could be months later that something else sad happens in their life. And that eventually brings out all those emotions about the loved one that they lost or the staff member that left that they haven't seen. So there could be other triggering events that continue to occur in their life, or they might hear, my friend's grandmother died. Well, now that reminds me of when my grandmother died. And again, with the strong visual memory and difficulty with passage of time, that might bring them right back to those feelings of grief. So oftentimes I'll see clients, I might work with them for several months, then we'll take a break and the parent might reach back out to me and say, well, we had this sad thing that happened. So now they're talking about that thing that happened several years ago that you worked with them on. So it's okay to do check-ins, and you don't want to, be upset with the family member or think they should have gotten over it by now, because what they're experiencing is distressing to them at that time, even though we think, gosh, that was so long ago, I can't believe they're still that upset about it. It is something that is real to them and should be addressed. Slower pace, now that would become an issue if it shifts into something more like a catatonic state, if they go from slow to almost getting like stuck in certain positions, like they can't move, or if the slowness is just even more extreme, or even sometimes people might even start talking slower. It's longer for them to get out words. That would be something else to look into. And then as far as the groove that we talked about, if the groove becomes maladaptive and the routine becomes more rigid, or there's increased difficulty transitioning them out of their routine, or that routine is no longer helpful to them, this would be a time that we would want to look and see if there's something else going on. All right, so a little bit about the groove. Like we said, there are some times where we need to keep calm and just let them get the groove on. The groove is a tendency to prefer sameness or repetition, a set pattern or routine in one's actions or thoughts. So a lot of times with my families, we have to talk about, is the behavior really negatively impacting their life and their ability to function? Or is the behavior just kind of annoying to those around them? Is it frustrating to us, or it doesn't make sense? Why do they have to do the same thing all the time? because a lot of times that is the issue, that the behavior is more just frustrating. And we can do some behavior modification to try to accommodate or make that behavior more accepting to everyone around them. But if it is affecting, leaving the house, they're not able to go to school or work, or they're more agitated or aggressive, then that would be something that we want to look more into. So the benefits of the groove, or this repetition and preference for sameness, is that the consistent schedule improves independent completion of daily living tasks. So I've heard of a lot of individuals that, they have the exact same morning routine or nighttime routine, and they have to do those things in the exact order every day. But they're able to do all of these things independently. So it's a way that they've adapted and learned how to do independent living skills. Sometimes this preference for sameness can be a coping mechanism. Does your family member like to watch the same show over and over, or listen to the same song, or color the same picture, or copy the same list over and over? Again, all of those things are very common. And this can actually be a calm down activity for them. It helps slow down their mind. It helps them process things that have been happening in their day. So it can be useful to them to actually do those activities. Often individuals with Down syndrome like to be employed at places where they have the same predictable schedule each day, and they can be very successfully employed. They know what they're doing and they show up for work ready to go, and this can be a good experience for them. They don't really get bored. It's actually decreases anxiety if they know what they're going to do every day. A lot of individuals with Down syndrome are also very meticulous about their appearance, the way they dress, or their environment. A lot of families have told me that their teenager with Down syndrome is the cleanest person in the house, and there's a certain spot for everything in their room, and they always know where everything is. It might be in piles, but they can find it. So again, some benefits to this. They might have repetitive conversations about the same topics all of the time. Again, for those of us that are with them all the time, you might get tired of hearing the same things over and over again, but this is actually helpful when they're meeting new people. It helps them connect with other people, and that person will remember them. Like, that's my buddy that likes to talk about the Carolina Panthers every time I see him, or whatever. So this can also help them make friends when they are passionate about something. So just another way to look at some of these behaviors. So the definition of obsessive compulsive disorder is an anxiety disorder with the presence of obsessions, compulsions, or both. Individuals will have recurrent and persistent thoughts, so those are typically the obsessions, urges or images experienced as intrusive or unwanted, resulting in anxiety or stress. So people typically do the behaviors or the compulsions because they're trying to make the anxiety or stress or disturbing thoughts go away. So they attempt to ignore or suppress thoughts, urges, or images by performing a compulsive behavior. So stereotypically, you might hear about the person who has the persistent thoughts of germs and not wanting to be exposed to any germs. And so they feel like before they leave the house, they have to wash their hands a certain number of times. So that would be a common behavior that people have heard about when you think about obsessive compulsive disorder. Now on this slide, we will see that individuals with Down syndrome have been and can be diagnosed with obsessive compulsive disorder, but there's still a lot to learn. In a study that was done recently of over 6,000 individuals with Down syndrome that had been seen over several years at the Adult Down Syndrome Center, It was found that individuals with Down syndrome had greater odds of experiencing anxiety disorders, specifically OCD, compared to their non-Down syndrome matched counterparts. If you search the name Ravelli, you can look up Ravelli Down syndrome mental health study, and you can see that they kind of went through all the possible mental health diagnoses and the prevalence that is found in the Down syndrome population. So that would be an interesting read as well. Some things with OCD and Down syndrome, however, are that there are likely different diagnostic criteria that need to be put in place before diagnosing someone with Down syndrome. As with a lot of mental health disorders, they might not check off all the boxes to be officially diagnosed, but it should be considered depending on, their experience and are they distressed and how is it impacting their life. On the previous slide about OCD, when we were talking about that they do the compulsive behaviors to try to get rid of those negative or distressing thoughts, it has been reported that it's less likely for people with Down syndrome to be distressed by their behaviors or intrusive thoughts. They might be fine with washing their hands a bunch of times. It doesn't frustrate them, or they might be fine with having to do X, Y, and Z before they walk outside. But we don't really know, are they not having intrusive thoughts, or are they just unable to express them, or they have difficulty expressing the thoughts that are bothering them? So that is another question that would need to be looked into a little bit more with OCD and Down syndrome. Obviously, continued research is warranted for Down syndrome and related mental health issues, and we don't really know, is OCD underdiagnosed or overdiagnosed? So obsessive compulsive disorder could be underdiagnosed if we are trying to check all the boxes that were on the last slide and the individual with Down syndrome is not reporting intrusive thoughts, or they don't seem extremely stressed. So somebody's like, oh, it's okay, they're not really bothered by it, so we'll just let it go. Or is it overdiagnosed? Obsessive compulsive disorder could be missed, or overdiagnosed if, again, you're with a clinician that's not familiar with Down syndrome. Maybe they say, yes, these are all obsessive compulsive behaviors, and let's try to treat this, when in actuality, it's their groove and it's their way of doing things independently and functioning. So just a few things to think about when you're thinking about your family member and OCD. Now, the grooves might become maladaptive or not really beneficial to the individual if they've had some kind of increase in stress in their life or some kind of change. A lot of times we will see that grooves become problematic, or they become more rigid with their grooves if something negative has happened to them recently. But I think the biggest thing when we're talking about diagnosing OCD and individuals with Down syndrome is, what is your family member's baseline? Is this a change in behavior? So just think about, I'll always ask families, they'll kind of describe what's going on now. And I ask, well, what were they like before? Or what were they doing 6 months ago? What's different now? So some individuals with Down syndrome may have always had rigid routines, or some individuals, this might be new to them. So that is probably the biggest indicator, is if this is a big change in your family member. All right, so when these behaviors would become problematic, some things that you might notice if their groove is starting to kind of shift over to the OCD or mental health issue. They might become increasingly agitated or aggressive when their routine is interrupted, whereas before, if you told them, all right, it's time to go, and they would transition easily, now they're getting more upset about it. refusing to attend required activities due to obsessions or compulsions,
Are you there, Michele?
Yes, I'm there. It just went
but we
quiet.
also had to be able to get to work, obviously. Let's see. And I haven't mentioned yet about sometimes OCD may be directed at another person. I've had several clients who almost seem obsessed with other people, whether it's teachers or staff or peers or friends that they've been around at different programs. So if it's starting to make the person that is the object of their obsession uncomfortable, this obviously would be other problematic behaviors might revolve around self-talk. So like we said earlier, that's a pretty normal thing, helps them think through things, process, cope with their day. But if your family member's self-talk changes, so if the tone becomes more angry, or when they're talking, it sounds like they're mad at themselves, or you hear them scalding themselves, or if it becomes more frequent, or they are talking in an imaginary conversations and they almost seem stuck in it. It's hard to get them back out and talking to you. Again, these would be other signs of problematic behaviors. When we think about how they like to be organized and keep things in a certain spot, or they might have certain piles where they know where everything is. If this method of organizing becomes unclean, or it's an obstacle, people are now tripping over their organized piles, then something might need to be adjusted. If their collection of favorite items, a lot of individuals with Down syndrome might have certain things that they like almost a hoarding situation, then we would want to work this out and try to adjust that behavior. And then lastly, if they are repeating questions about an upcoming event excessively, maybe asking the same question over and over, even though you've answered them, explained it to them, this is a good indicator that they are having anxiety or stress about an upcoming event. So these are just a few, I guess, red flags to look out for if these are new behaviors. And just a side note, another resource for mental health and Down syndrome is the National Down Syndrome Society, and they have a whole section on mental health and inclusive mental health and how to work with people with Down syndrome and develop mentally healthy lives. All right, so as we all know, all behavior is a form of communication. So sometimes, or all of the time, before making a diagnosis, you need further assessment or to look into other areas and just make sure that all avenues have been reviewed. Because we need to ask ourselves, is it OCD, or are the OCD behaviors a symptom of something else? Like, what exactly do we need to be treating? Obviously, there are some common medical concerns across the Down syndrome population, whether it's sleep issues, thyroid dysfunction, gastrointestinal problems, chronic pain, or infections. Obviously, all of these can affect mood and behavior. If we just think about ourselves, think about if we're not sleeping good, what is our attitude like the next day? Worse. And so a lot of times increased because they're trying to accommodate their stress over not sleeping. So they might try to keep things more organized so they have some kind of control over what's going on. And it's often difficult for individuals with Down syndrome to explain if they're in pain or where they're hurting or what it feels like. So sometimes medical issues might actually come out as a mental health issue. Maybe they're seeming more depressed, they're not wanting to go to things, but maybe it's because they're in pain and they don't feel good, and we haven't really figured that out yet. So I always ask families when I'm starting with them just to make sure that they've had a recent medical checkup, just to make sure that nothing is out of whack or if there's anything else that needs to be further explored. I also want to know about any life transitions that have happened, like maybe the OCD behaviors are about control and keeping things consistent in their life because they've had changes recently. It could be changes in family dynamics, whether there was a divorce or a death in the family, a staff person that was like family, that was with them a lot, that's not working with them anymore. These are all things that can be very traumatic to individuals with Down syndrome, obviously. Or a change in residence, even if they moved with their family, but they're in a different environment, that can be stressful. Or if they've been excited about moving into their own house or apartment or group home living, it's still a change and it'll be an adjustment. So in order to feel like they're successful there, maybe they amp up the routine a little bit to feel more independent and learn their way around. And also, as a lot of you know, if you have older teens and adults, finishing school can be stressful for individuals with Down syndrome because unfortunately, there's not as many activities and they're used to being in school, the structured environment all day, every day. And now they kind of have to piece together what they're doing. Or maybe they are worried about starting a new program or starting a new job. Again, these could all be things that they were excited about, but it's a change. So are these things causing stress? And is that why behaviors have increased or changed? And then lastly, I feel like I can't do a mental health presentation regarding Down syndrome without at least mentioning Down syndrome regression disorder at this point. Oftentimes with this disorder, there may be an increase in OCD behaviors, but this would often be coupled with a lot of other things. Obviously, regression, loss of skills over weeks or months, behavior, sleep, neurological changes, language changes or difficulties, irregular movements, and just always know that this diagnosis is a diagnosis of exclusion. So we would always look at all these other things, all of the common medical issues, all of the mental health concerns that could be there, the stress that's involved before we would diagnosed with this disorder. But again, OCD behaviors could be a symptom of that. So is it OCD or are the OCD behaviors a symptom? Just something to consider. For treatment, obviously, treatment of OCD, like any other mental health issue, would involve counseling. As I've mentioned several times, if possible, try to find a therapist familiar with Down syndrome or at least intellectual disability so they know how to present material and modify treatments so that it can work for individuals with Down syndrome. And I do have a lot of families that are confused or often don't know who can provide counseling. I'll still have people call me and say, well, I'm looking for a psychologist. And I'm like, okay, well, what service are you wanting? Well, I need counseling. And I'm like, okay, well, I'm not a psychologist, but I can provide counseling. So this is just a brief overview. And I can see how it can be very confusing because I had to look up some people to add to this list as well. So there's a lot of people that are available for this service. For example, myself, like I mentioned, I'm a licensed clinical social worker. In North Carolina, that means I'm an LCSW, but in South Carolina, that means I'm an LISWCP. So I understand the confusion. So licensed clinical social workers can provide counseling, a licensed professional counselor, a licensed clinical mental health counselor, licensed marriage and family therapist. All of those people can provide counseling. Now, a psychologist, you will always have a PhD or other doctorate, so they're always going to be a doctor, somebody. And the difference between a psychologist and the other counselors that I previously mentioned is that they can do psychological testing and educational testing and IQ testing. We can do assessments and diagnose people and provide counseling, but we don't do the strict testing like psychologists do. So psychologists can do testing and counseling. And then there's also psychiatric nurse practitioners. They have a lot of letters to describe their name, but they provide counseling as well. And psychiatrists, even though they're mostly thought of to provide medication, they can provide counseling with their med management services, and they will be an MD, a medical doctor. So just wanted to briefly go over that to give you some information because it can be very confusing. All right, the counseling piece, those are all the people that can do that. And then usually a combination of counseling and medication is what is best to get through these mental health diagnoses. Again, if possible, find a professional that is familiar with Down syndrome or intellectual disabilities. A psychiatrist can provide medication, and also a psychiatric nurse practitioner that I listed on the other side. So both of those people can do counseling and provide prescriptions and med management. Sometimes nervous system regulation is needed, and that would entail working with the occupational therapist. This comes into play a lot of times with anxiety. You know, when you think about the side effects or what happens to your body when you're feeling anxious, whether your hands get sweaty or your heart starts beating fast, these are all body reactions, and sometimes our nervous system needs to be regulated in order to calm down the anxiety. So an occupational therapist is someone that could help with that. And again, they work with all ages, not just kids. And then lastly, for behavior modification, a lot of times I include that in the counseling process, but a board certified behavior analyst, or maybe you've seen a BCBA, they most likely will work in the home or community and can come help implement maybe behaviors that they have addressed in counseling. Maybe they help implement them in the home. So that is the who of treatment, who can help you. And the what of treatment. So a little overview of counseling with individuals with Down syndrome, because a lot of people will ask me, well, what is it like? They're not just going to sit there and talk to you and tell you all their problems. What is it going to be like? Talk therapy? That's not going to work for them. And some of them will sit there and talk to me and tell me all their problems, and they love it. They just like having somebody to talk to that is not in their family, and that can be very beneficial and therapeutic. But typically when I'm working with this population, I use a lot of visual aids. Even with adults, a lot of times families will say, well, we used to use printouts or schedules or different visual aids when they were a kid, but we haven't so much anymore. So I'm here to say, bring back the visual aids for teens and adults. Try to find things that are age appropriate, so you're not giving them like cartoon things. But I use a lot of visuals. That could be printouts, or I'll show a lot of videos, role play interactions, things like that, so they can actually see emotions and see behaviors, and then we can talk about it. Counseling with individuals with Down syndrome is oftentimes more directive than it is with you or I. So I'll do a lot of psychoeducation, maybe just teaching them what is depression, what is anxiety, or those feelings that you're having in your body. You're not going crazy, like calming that down. A lot of times they haven't learned what any of those things are. So just teaching them about the mental health diagnoses and what's going on with them can be beneficial. And then I typically go into sessions with almost like a lesson plan, depending on the issue that they are there to address. I might say, okay, I'm going to teach them a little bit about anxiety today, and then we're going to practice some new coping skills. And then we're going to put together our own visual aid to give to the family of what calm down activities that we're going to start working on. So just to give you a little picture of what counseling with individuals with Down syndrome can look like. Medications that are often beneficial for obsessive compulsive behaviors are SSRIs, or selective serotonin reuptake inhibitors. And the most common one that is prescribed to individuals with Down syndrome is Zoloft. Now, it might not make the obsessions or compulsive behaviors disappear, but typically it will reduce the intensity of the thoughts or behaviors so that you can more easily redirect them or transition them. And then occasionally, say if the self-talk has gotten more angry or violent, or they're getting more stuck in the imaginary world, things like that, occasionally an antipsychotic might be needed. So I won't go into all the medication stuff, but those are just like the most common responses. For nervous system regulation, like we said with the OT, or sometimes I use these tools in counseling, and you can do them at home. Proprioceptive input, whether that's just, you hear about weighted blankets or a weighted vest, or jumping, or doing the bear walk across the floor, anything for them to get like heavy input. And then interoceptive exercises, I've started hearing more about recently, to calm anxiety. And that is more like mindfulness and body awareness, just noticing what feelings they're having in their body and to see if they're able to calm them and change the sensation. So it's really just recognizing the feelings that they're having throughout their body. And as previously mentioned, behavior modification, it can be a part of the counseling process or involve another professional. And then obviously, since OCD is an anxiety disorder, we most likely need to do something to treat the anxiety, and that would be done in the counseling process. And I'll talk a little bit about that in a minute and give you guys some resources of coping skills that y'all can practice at home. Okay, so when we talk about behavior modification and what can we do to try to adjust these routines that have become more rigid or get back to making them more beneficial, a few things that you can try, or not a few, I guess a whole page of things, but try to find times in the day to accommodate the behavior. Like I said earlier about my guy that had to make his lists and he couldn't go to work. Well, that behavior was obviously really important to him, the list making, but the job needed to be more important. So we made a visual schedule for his day so that he knew he would have some time in the day or multiple times in the day that he could do his list making, because that settled him. So as long as he knew that he was going to be able to do it at some point and it wasn't getting taken away from him, that helped him to be able to get back to work and do other important things that he needed to do. Sometimes we just need to accommodate the behaviors. Again, depending on the severity of the issue, we might just need to allow extra time. Knowing that it's going to take them this long to finish their morning routine, we're just going to have to get them up earlier so they can do all the things that they need to do. Sometimes we need to identify an appropriate place for the behavior. We've used this a lot if a person is maybe obsessed over something that happened, so they just keep talking about the same thing over and over. And I've had families that are like, I just can't validate it anymore. We've done that. I can't listen to it anymore. It's starting to frustrate me, which is understandable. So after validating them and telling the person, we're sorry, whatever happened that they're upset about, we may identify an appropriate place. Go to your spot in your room, and I'm going to set a timer, and you can go talk about it for however many minutes. And then I want you to do these 2 calm down activities to make yourself feel better. So just giving them a place to do it so they're not holding it inside. And like I said, we might use timers. I've used playlists. You know, I have some guys that they have to take a shower every night at 7, no matter what the rest of the family's plans are. And it might be a really long shower. So in order to try to modify that a little bit, I'll have them pick 2 or 3 of their favorite songs, depending on how long the songs are, and say, okay, when these songs are over, that means that it's time to get out of the shower. So you're giving them an exact window of time for them to do their necessary behavior. Again, visual aids, very important. It could be something as simple as a first then, like first I need you to do this necessary task, then you can do this task that you like to do that makes you feel better or calms you down. Like I mentioned before, a daily schedule, just showing them times throughout the day that they're going to be able to do those repetitive behaviors that they like. And then using social stories to explain their routine and their life and how they can do these behaviors and how they can calm down. I've started putting together some social stories that are more adult friendly. So I will give you that resource too to check out at the end. Using transition items or letting them know way in advance about a transition, like, hey, you need to finish this routine, we're leaving in 5 minutes. Again, you can combine a lot of these things, show them on the daily schedule, set a timer, find something, an object that is calming to them, and try to use like as few words as possible. Sometimes just having the conversation and talking is like too much for them to listen to, but they might know, okay, when mom gives me this item, that means it's time to go. Coping skills, I will get a little bit more into, but some common ones that I use in this population are journaling, deep breathing, and muscle relaxation. And relationship education might be necessary for those that are obsessed with other people. Maybe we need to teach them about appropriate boundaries and what a healthy relationship looks like and how to develop relationships. Or maybe we need to do some role plays or show them some videos and see, like, how does this person look when this person keeps coming up to them and saying the same thing over and over? Does it look like they're feeling uncomfortable, or do they look happy about it? How can you tell? Look at their face, look at their body. So I like to do, again, a lot of visuals. If they have a show that they like to watch over and over, or a movie they like to watch over and over, you can use that to your benefit and look at it a different way and point out interactions in the show. How were they acting towards each other? Did you think that was a nice friend? How were they talking to each other? Was that a kind voice? So again, anything that they can see, it will help them learn a little bit better. Teaching about compromise and flexible thinking, giving them choices throughout the day. Increased physical activity, of course, can help with a lot of mental health issues. So if you're finding that they're not as active, try to find one thing that they like to do. Most of my clients like to dance. Even if they don't like to work out, if their favorite song comes on, they're going to get up and move around. So just trying something simple like that. Increasing social opportunities and meaningful activities. I've found that most of my clients that are at home more and not out and about with peers or engaged in different things or working or school have a more difficult time moving past these mental health issues. And my people that are engaged in the community and seeing buddies and friends all the time, they seem to have a quicker turnaround when they are having mental health issues. And another resource, again, this is for all ages, Supporting Positive Behavior in Children and Teens with Down Syndrome. This is a book and it is available on Amazon. All right, so when we talk about treating anxiety, I'll just give you a couple of basic coping skills, and you're never too old or too young to learn how to do these things. But when we're talking about anxiety, like I mentioned earlier, it's important to teach the individual about what anxiety is and what is going on in their body and why they feel that way, and try to normalize it. Talk about times when you felt nervous or anxious, or if you have anxiety, explain to them what has helped you. And then with most mental health issues, increasing emotional literacy is important. So that means their feelings vocabulary. So try to have conversations each day about how are they feeling, and don't settle for fine, good, or okay. Try to present them either with a list of words or faces, giving them options of different emotions that they can talk about. So the more they talk about it when they're having difficult emotions, it will be easier for them to explain if they talk about it more when they're calm. And again, when we were talking about shows, you can use that, point out people's faces. How do you think that person is feeling? How can you tell? Or that person looks upset. How would you help them calm down? Just fitting conversations like that in throughout the day can be a good way to improve mental wellness. And lastly, a few coping skills that you can do at home to try to calm nerves. Deep breathing, and a simple exercise to get them to breathe the right way is to tell the individual to smell a flower. So they would breathe in through their nose like they're smelling something really good, and then blow out through their mouth like they're blowing out a candle on their birthday cake. So this teaches them to breathe in through their nose and out through their mouth, and take slow, long breaths. And again, using a visual to show them how to do it. With teens and adults, if they have their own phone, they might save a picture of a flower and a candle on their phone and then pull it out to remind them of what to do when they need to calm down. Muscle relaxation, that can be as simple as giving yourself a big hug as tight as you can, and then telling them to relax their arms like spaghetti, or squeezing your fist and then relaxing, or bringing your shoulders up to your ears and holding it and then relaxing. And then grounding, that is what is in the 5, 4, 3, 2, 1 picture. And this is an easy technique you can do, and it's good for anxiety because most of the time when we're feeling anxious about stuff, it's things that are either coming up in the future or happened in the past. So with grounding, it helps us focus on the present. And again, this can be done with all ages. So you just tell them to sit and look around the room wherever they are and name 5 things that you see right now. It could be a light, a curtain, a wall, a phone. And then think 4 things they can feel. They can either reach out and touch 4 things, or they can say, I feel my shirt on my arm, or I feel my feet on the floor. Again, they're focusing on their immediate surroundings. And then you just keep going. 3 things you can hear, 2 things you can smell, and 1 thing you can taste. And that's usually the hardest one. So if they can't come up with anything, you can just tell them, what's your favorite taste, or what's your favorite thing to eat? And then lastly, journaling is good for everyone with anxiety, because a lot of times we have a lot of thoughts swirling around in our head, and that's what makes us anxious. And this could be writing. For younger kids, this could just be giving them a happy, sad, and mad, and say, pick out a color for each of those emotions and draw what those feelings look like. For those that have their own phones, they can do a voice recording journal. Again, it's just to get what's going on in their head either out, just away from them. So those are a few things that you can try at home to calm anxiety. So these are the mental health resources and visual, where you can find and print a lot of visual aids. And again, I think they're going to send all this out to you. But the Adult Down Syndrome Center resource page has a ton of visuals and videos made by people with Down syndrome demonstrating different things. You can find almost every topic there, and you can select what's appropriate for you or what you need help with to print out. The Down Syndrome Resource Foundation has a lot of information on their page, and they also host the Lowdown podcast. If you've never listened to that, there are several about mental health, actually, if you want more information. And then Down Syndrome Connection of the Bay Area has a mental health Padlet on their website. And this has a bunch of printables, visual aids, again, all related to mental health. And then lastly, I've recently started a Teachers Pay Teachers shop, and it has some of the social stories I've written. It has some of the calm down visual aids. So you can check that out as well. And then I always like to end with this, because I always feel like I share too much and I don't want to overwhelm you, but I just want to remind everyone to focus on 1% better every day. So for those of you that don't know, this is Chris Nikich, and he was the first man with Down syndrome to complete an Ironman race. And he does motivational speaking, and he talks about his philosophy of 1% better every day. So he says when he first started training, he could only do 1 push-up and 1 sit-up. So the next day, he didn't try to do 50, he just did 2. And then the next day he did 3. So that's what I mean by 1% better every day. Don't feel like you need to look into all these professionals or start practicing all these activities or implement all of these things or start assessing everything that we've talked about today. Just try to make little tweaks in your routine and schedule, and everything will improve 1% better every day. So thank you guys for listening. I think I finished right on time. Is that right?
You were on the money, Michele. We just want to thank you again for your amazing thoroughness and all things mental health and supporting us in our community and giving very next step solutions and strategies to make that possible. I did